Hi all, I am recording this for the second time because apparently I did not have my microphone on when I recorded the same lecture before. So sorry for that, I will get on with it. So this is part 2. In continuation with what we discussed yesterday, I will be continuing with discussion on steroid dependent, frequently relapsing nephrotic syndrome. How are you going to manage and the algorithm? So this will be my flow of presentation. We will look at multiple definitions. We will see how to manage a case of steroid dependence or frequently relapsing nephrotic syndrome, and we will discuss just salient points about the medications used. So what is remission? You call a nephrotic syndrome child to be in remission if the urine protein is nil or trace in dipstick. Urine protein creatinine ratio is less than 0.2 milligram per milligram in 3 early morning consecutive urine samples. This is remission. What is relapse? Relapse is the opposite. So you have a nephrotic range proteinuria. If you remember the definition of nephrotic range proteinuria, you can say this. The child was initially in remission, but now child has come with urine protein of 3 plus or more, urine protein creatinine ratio of more than 2 milligram per milligram for 3 early morning consecutive urine samples. Now that we know the definition of relapse, what do you mean by frequent relapse? So frequent means there should be some number, right? So remember 2, 3 and 4. What is 2? 2 or more relapses in the first 6 months after stopping initial treatment or while on treatment. 3 or more in any 6 months. Any 6 months in the sense, suppose this is the calendar, imagine, and you have January, February, March, April, May, June, July, August, September, October, November, December. Then you have the subsequent year starting, and in subsequent year again you have January, February, March, April, May, June, July, August. Okay. So you have a child who is falling or who is falling sick, who is having a relapse in December of the previous year, then again having a relapse in February, having a relapse in March. So what do you call this child? You cannot say child is having just 2 relapses, so I will not call it as a frequent relapser. This child will still be called as a frequent relapser because within any 6 month period. So if you take December as the first month, so December, January, February, March, April, May. So in this 6 month period, this child has had 1, 2 and 3 relapses. Got my point? So any 6 months 3 or more relapse. Similarly in any 1 year, any 12 months 4 or more relapse. You call it as a frequent relapser. Clear about the definition? 2 or more in the first 6 months after stopping initial treatment. 3 or more in any 6 months. 4 or more in 1 year. What is steroid dependence? Steroid dependence is 2 or more relapse while on alternate day steroids or within first 2 weeks of stopping initial treatment or stopping alternate day steroids. So frequent relapse is 6 months duration. Note this point. Okay, 6 months is your frequent relapse, whereas 2 weeks you have your steroid dependence. Note this point, remember this point, this is very important for your definitions. So for the purpose of this discussion, frequent relapse, steroid dependence are discussed in one and the same umbrella. So suppose you have a child who is fitting the definition of a frequent relapser or a steroid dependent case, then the first choice of treatment will be starting on prednisone alternate days. Okay. So suppose this child is frequently relapsing on prednisone or this child is having steroid dependence, whatever reason, you look for 3 risk factors. Why do you look for 3 risk factors? Because that is going to determine your course of action, your choice of medication. So if the child's steroid threshold is more than 1 milligram per kilogram on alternate days, what do you mean by steroid threshold? Steroid threshold na it is the minimum level of steroid that is required to maintain a nephrotic child on remission. Okay, minimum dose of steroid that is required to maintain this child in remission. So if this is high, if there is a high steroid threshold, child requires at least or more than 1 milligram per kg on alternate days to maintain in remission, or this child is having more than one complicated relapse, or this child is having significant steroid toxicity. So, these are the 3 points you will look for. Steroid threshold, I told you the definition. What is meant by complicated relapse? So, relapse coming with complication. What are the complications? 3 complications. One is hypovolemia, 2 severe infection, 3 is thrombosis. Okay. So, you can remember it as systemic hypertension, though none of these disorders are going to present with systemic hypertension. Okay. So, SHT. S is your severe infection, H is your hypovolemia, or T is your thrombosis. Okay. You can also remember it as HIT. Hypovolemia, infection and thrombosis, whichever way you want to remember you can. Okay. So, but these 3 things constitute a complicated relapse. A child with relapse coming with any of these 3 you will call as complicated relapse. What do you mean by significant steroid toxicity? Whenever you have a child who is on long term steroids, you do expect some adverse reactions to happen. What are they? Hyperglycemia, defined as fasting glucose of more than 100, postprandial more than 140 and HbA1c more than 5.7. Note that this is way less than your diabetes mellitus definition. Okay, they are not one and the same. So, while on steroids, if the child is having more than 100 fasting glucose, more than 140 postprandial and more than 5.7 HbA1c, you call it as criteria for steroid toxicity, significant steroid toxicity. If the child is meeting the criteria for obesity, more than 95th percentile, child is having short stature as evidenced by height less than -2 standard deviation and or a height velocity of less than 3 standard deviation, raised intraocular pressure, not intracranial, it is intraocular pressure, cataracts, myopathy, osteonecrosis or psychosis. So, among this, if any of the criteria is met, you call it as significant steroid toxicity. So, what are you going to do assessing these 3? If none of these 3 criteria is met, steroid threshold is less than say 0.7 milligram per kg, the relapse is non-complicated or uncomplicated, yeah, I think that is the correct word, uncomplicated relapse, and there is no significant steroid toxicity, then your choice of medication is between levamisole and mycophenolate Morphetel low dose. Suppose if any one of the factor is yes, the answer to the question is yes, then your treatment of choice is between mycophenolate Morphetel high dose or a cyclophosphamy. So, how do you choose between these 2? If the child is of older age or if the child is of peripubertal male, then mycophenolate Morphetel is preferred. Younger age, cyclophosphamide, I think I said it completely ulta. Cyclophosphamide more than 7 years you can give, less than 5 to 7 years you do not give because it is not effective. Peripubertal males you do not give because of gonadal toxicity. If these 2 conditions are there, then mycophenolate Morphetel will be preferred. Suppose a child fails this therapy, then you will shift over to high dose mycophenolate Morphetel or cyclophosphamide. Suppose this therapy also fails, then you call it as a difficult to treat disease. What do you mean by difficult to treat disease? 2 criteria for difficult to treat disease: frequent relapse or steroid toxicity, failure of more than or equal to 2 steroid sparing agents, levamisole, mycophenolate Morphetel, cyclophosphamide. Okay. So, these 2 criteria are met, then you call it as a difficult to treat disease, frequent relapse or steroid toxicity significant. Second one is 2 or more steroid sparing agents have failed to keep the child in remission. Then your treatment of choice is calcineurin inhibitors, CNI, cyclosporin or tacrolimus. If this also fails, then it is rituximab. Remember, rituximab, younger child has to be used with great caution because younger the child, there is higher risk of hypogammaglobulinemia. So, whatever you remember or do not remember, please remember this one page. I will be sharing this page in our Telegram group. So, please download and keep it. Okay. So, let us see about each of the medication in short. The first choice of drug for a frequent relapser or a steroid dependent nephrotic syndrome is long term prednisolone. You will start at 0.5 to 0.7 milligram per kg on alternate day. Duration is 6 to 12 months. If the child is in sustained remission for the first few months of this complete duration of therapy, then you can decrease the dosage from 0.5, 0.7 to 0.2 to 0.3 milligram per kg on alternate day. The lowest possible steroid dose to maintain the child in remission is ideal to decrease the adverse reaction, decrease the steroid toxicity risk. Suppose this child is on this sort of long term prednisolone. There is some infection. Do you know which is the most common infection that causes relapse? It is upper respiratory tract infection, simple cold, common cold. There was one question by Dr. Anisha in the comment section. So, she had asked, how do you prevent a child from getting relapse while on prednisolone? What advice do you give? So, you tell the parents, in case of any symptom of infection, the child is having some runny nose, some cough, some fever, bring the child immediately to the nephrologist or the primary caregiver. So, at onset, you will convert this alternate day steroid to daily dose steroid at the same dose, and you will give it for 5 to 7 days. If you do this, this will prevent relapse. Okay. So, this is about your so-called stress dose steroids while on alternate day therapy. Usually, it is at a dose of 0.5 milligram per kg. Instead of alternate day, you will be giving it daily for 5 to 7 days. So, this green box is it's an ongoing area of study. They are trying to see whether this alternate day dose is better or a lower dose given daily, 0.2 to 0.3 milligram per kg daily. And some small studies, they have pointed that this lower daily dose is better compared to that of a higher alternate day dose, but further randomized control studies are required to actually point us in the right direction. So, this is about long term prednisolone. Adverse reactions you already know, so I am not going to touch upon that. So, if this therapy fails, you are left with a choice between levamisole versus MMF if the child is not having the 3 points. If the steroid threshold is low, child is not having significant steroid toxicity, and child is not having a complicated relapse. Levamisole. So, if you see, the risk of relapse is similar to that of mycophenolate mofetil and cyclophosphamide. The dose of levamisole is 2 to 2.5 milligram per kg on alternate day for a duration of 2 to 3 years. Okay, it's not 6 to 12 months, it is 2 to 3 years. The adverse reactions that you will be watching out for is neutropenia, increased transaminases, and ANCA positive vasculitis, anti-neutrophilic cytoplasmic anti-neutrophilic cytoplasmic antibodies. Okay, I am not sure if I am making a mistake, slightly hypoglycemic here. Right, so this is about levamisole. Mycophenolate mofetil, it's a safe drug. Its relapse rate is comparable to that of your levamisole, but less than that of cyclophosphamide. Mycophenolate mofetil is more effective if the child is younger and if the child is having a steroid dependent state than a frequently relapsing nephrotic syndrome state. The dosage of MMF varies from 600 to 1200 milligram per meter square. So, for an uncomplicated child, you will start at a lower dose, 600 milligram per meter square or your 20 mg per kg per day, and you will escalate it if the child is going to continue to relapse. You will monitor MMF by doing an area under curve, drug levels you will do, and it's ideal to maintain it above 45. Duration is 2 to 3 years. So, suppose your levamisole or your mycophenolate mofetil therapy fails, then you are left with a choice between cyclophosphamide or a high dose MMF. High dose MMF is preferable in younger children and peripubertal male simply because cyclophosphamide is not effective in young children and it causes gonadal toxicity in peripubertal male. Cyclophosphamide and levamisole, your relapse rate is almost same, but it is less than that of cyclosporin. Cyclophosphamy is more effective in a steroid dependent state rather than a frequently relapsing nephrotic syndrome, and it is advisable to give it in more than 5 to 7 years age group. Less than 5 to 7 years, it is not as effective. What dose do you give? You give it in 2 to 2.5 mg per kg daily dose. Alright, so this is a daily dosing. What duration you will give? It is just 12 weeks. 8 to 12 weeks is the range. Maximum is 12 weeks, which will give a cumulative dose of around 168 milligram per kilogram. Along with prednisolone. Prednisolone you will give 1 milligram per kilogram on alternate day, and it will be stopped in the next 1 to 2 months while on cyclophosphamide. Remember, cyclophosphamide is preferably started while the child is in remission rather than while the child is actively having nephrotic syndrome. What are the adverse reactions do you expect after a cyclophosphamide? Hemorrhagic cystitis, gonadal toxicity, malignancy, all of you know. The practical point is you will monitor for leukopenia. So, you will do a CBC every 2 weeks. You will look for leukopenia. Any value less than 4000, you will stop cyclophosphamide therapy. Clear? This is about cyclophosphamide. If this therapy fails, then you are left with calcineurin inhibitors, which is cyclosporin and tacrolimus. So, depending upon the age group, I think one drug choice might be better than other. For example, in adolescent, they might not be very happy with the cosmetic side effects of cyclosporin, which includes hypertrichosis, gingival hyperplasia, etc. Right? So, in those patients, tacrolimus might be preferable. Cyclosporin, the advantage is it is available in syrup format. So, for younger kids, cyclosporin, giving a cyclosporin might be easier, might be being the keyword. The duration of therapy is 2 to 3 years. Your cyclosporin you will give at 4 to 5 milligram per kg per day in divided doses with a trough level of around 80 to 120 nanogram per ml. The adverse reaction of nephrotoxicity and hyperkalemia is common to both. This cosmetic side effect is specific for cyclosporin. Metabolic side effects of hypertension and dyslipidemia again has to be monitored in a child with cyclosporin. Tacrolimus, the dosage is 0.1 to 0.2 milligram per kg per day with trough level of 4 to 8 nanogram per ml. The adverse reactions apart from nephrotoxicity and hyperkalemia are tremors, seizures, glucose intolerance and hypomagnesemia. So, you have given a cyclosporin therapy for 2 years or a tacrolimus therapy for 2 to 3 years, but still child is relapsing. That means your treatment has failed. So, the last weapon in your armamentarium is your rituximab for a steroid sensitive nephrotic syndrome, that is. We are still discussing steroid sensitive, remember that. Okay. So, rituximab is a monoclonal antibody against CD20 which is found in B cells. The dosage that you give is 375 milligram per meter square. This is a body surface area based dosing. The route is intravenous. It is given once a week. You can give up to 4 doses. 2 is preferable. Why not just 1? Because studies have shown with 1 dose of rituximab, child relapses around 9 months. With 2 doses of rituximab, the remission period is more prolonged, on an average at least for 1 year or 1 year and few months. Hence, 2 doses is preferred. How do you know this 375 milligram per meter square is the adequate dosing? You will look at B cell depletion. When do you check for B cell depletion? You will do it 2 to 7 days after the last dose of rituximab. What are you going to check for? You will look at the percentage or number of CD19 positive cells among the CD45 positive cells. So, if CD19 cells are less than 1% or less than 5 cells per microliter, then it means your treatment is effective. Suppose you find the percentage is more than 1 or the cells more than 5 among the CD45 cells, then you can give 1 to 2 additional doses of rituximab. Okay. And again, similar to your cyclophosphamide, treatment is preferred while the child is on remission. What are the things you are going to be monitoring for? Especially hypogammaglobulinemia, which is inversely proportional to that of age. Younger the child, higher the risk of hypogammaglobulinemia. So, you have to be very, very careful. Serum sickness like illness has been reported, bronchospasm, acute lung injury are adverse reactions. So, you need to monitor the child while you are giving infusion of rituximab. If the patient is initiated on say any other immunosuppressant after rituximab, you very well know that B cell recovery takes around 6 to 9 months, isn't it? So, that is what we discussed in our last class. So, B cell recovery takes 6 to 9 months. So, you will have to wait for that much time before giving any sort of live vaccine, correct? So, if you are going to initiate a child on a calcineurin inhibitor or a mycophenolate Morphetel after rituximab therapy, then cotrimoxazole prophylaxis has to be given. how much will you give? 5 milligram per kg of trimethoprim component on alternate day has to be given. So this is about your steroid dependence and your frequently relapsing state. Hope this class was useful to you. If you have any doubts, please message in the Telegram group. It will be easier to keep track of doubts and I'll try to clear it as early as possible. So thank you guys. Share this lecture with your colleagues, with your juniors who are in the pediatrics field, who are managing kids, and this will be useful to them. Thank you all for listening to me patiently, and all the best for your exams. Bye bye.